Hello, everyone. I'm Khushbu Agarwal. I'm a senior computer scientist at Pacific Northwest National Lab. And today I wanted to share our recent work in building predictive models for predicting COVID-19 outcomes using all modalities of healthcare data, including clinical notes and lab measurements and structured data. And I'm going to talk about this model in context of predicting COVID-19 outcomes from very limited amount of data. So let's get started. Okay, so before we jump into all of the cool technical stuff, I want to take a minute to introduce our team. The work that you will see today is jointly done in collaboration with Shutne Chaudhary, Colby Ham at PNNL, Suzanne Tamang, Dr. Matthew Baker, Preetham and C at Stanford University, Sindhu and Dr. Chandan Reddy at Virginia Tech, and with a significant amount of help from Vessel Kaufman and David Talby at John Snow Labs. And we had multiple publications about this work over the last 2 years. Okay, so this work that I'm going to talk about today started when actually COVID hit in March 2020. So we had a collaboration with Stanford University, Dr. Suzanne Tamang, and we were talking about as COVID patients were coming into the hospital, it was very hard to know which patients were at highest risk of severe outcomes. So, as a patient would come in, first of all, there would be no history associated with the patient in the hospital. And as the patient would come in, it was hard to do resource planning or understand what was driving severe outcomes for for different patients in the population. And also, it was hard to know how long the patients would stay, or should the hospitals plan for them to stay, what kind of resources would be needed in terms of ventilators or ICU beds, and so on. So, when we started doing this work, what we wanted to do is take off the shelf models and look at the data that was being collected as the patients were coming into the hospital and say, can we do a good job at predicting what is the likelihood of severe outcome for a given patient? And we started looking at existing off-the-shelf models, including, BERT-like models. But we determined most of the models actually needed significant amount of supervised labels and training data. And one thing we did not have with COVID was enough number of samples or training data. So we started working on this idea that we wanted to solve two things for predicting COVID-19 outcomes. One was we needed a model that can work well and train well with limited amount of training data. And another was we also wanted to see how, so as the patients were coming in, the most of the data that was being collected was actually in form of clinical notes and lab measurements, which was significantly different from most of the models in EHR modeling, which generally take structured symbolic codes. So we wanted to build a model then that can take all different kinds of patient data, so including clinical notes, lab measurements, structured EHR, and also have that model work with limited amount of training data. And the work that you will see here, I'm going to discuss today, is in the context of that study we did with Stanford University Medical Center for predicting COVID-19 outcomes by taking 9 months of COVID patient data from their center. Okay, so let's get started. So I talked about two primary challenges in predicting COVID-19 outcomes. So let's talk about the first one, which was limited data. So as patients were coming in, as I said, these patients did not have a large longitudinal history associated with them. The patients would just come in, and actually when this work started, we only had 454 COVID patients, and very few of them actually, a smaller percentage of them actually had ICU or ventilator outcome. So it became really hard for us to train a supervised model with this kind of outcomes. So we started talking actually to the doctors there. And one thing that became clear as we started working on this was COVID was very similar to other respiratory diseases, but slightly different. So the severity was a little different, but there were common conditions, how the patients were deteriorating. There were similarities with previous respiratory diseases. So one thing we started to look at was there a way for us to integrate the things that we knew about other respiratory diseases into our deep learning models? So what we did was we looked at the data for the other respiratory diseases. I'm referring to SRD as the severe respiratory diseases in the Stanford Medical Center, and started comparing the different statistics associated with COVID and the severe respiratory disease patients. So here what you see is the length of stay associated with COVID and SRD, and we saw that that was very similar. The age distribution was slightly different, but the what you see in the bottom, the diagnosis codes, the procedure codes, the drugs that were being given, the lab measurements that were being taken for COVID patients actually were very much common in what was being used to treat or diagnose the other respiratory disease patients. So, for example, here we observed that out of the 2,599 diagnosis codes that were associated with the COVID patients, 2,310 were actually also observed in the other SRD cohort patients. And similarly, 1,204 procedures were common between COVID and SRD, and so on for the drugs and lab measurements. So, what we started thinking about is there a way for us to train or use this data from SRD cohort to train the model and then kind of fine tune on the COVID outcome? So we started looking at more of the transfer learning approach for doing the COVID-19 outcome prediction. Okay, so before I talk about how we solved that idea of integrating two different kind of cohorts, I want to first talk about another challenge that we had with COVID patients. So I mentioned earlier, as the patients were coming in, most of the time they were de novo patients. So there was not enough longitudinal EHR symbolic data associated with these patients. And what we wanted to do was take the as they were coming in, the most of the doctors were writing clinical notes about what they're observing in the patient. And most of the time, the historical data associated with the patient, like their risk factors about diabetes or cholesterol or hyperlipidemia or any of the coronary conditions, that was also present in clinical notes. So it became really critical for us to extract most of this information from clinical notes and incorporate that into our model. So next, what I'm going to talk about is how we took the clinical notes and extracted different kind of patient risk factors using Spark NLP. So what we started doing was started looking at the different sets of blocks that were in the clinical notes and seeing which are the different features that are relevant to COVID that we want to extract. And at that time, we were talking to Vessel and David Talvey from Spark NLP, and they gave us actually a license to use Spark NLP tool to extract this kind of markers. So what we did was we were able to extract the markers for diabetes, hypertension, obesity, smoking, coronary artery disease, hyperlipidemia, and a list of medications that the patients was taken as they were coming in. And not only that we could extract these presence of these entities, it also gave us an assertion if that was actually present in the patient or it was not present. So if you've worked in clinical notes, you know that most of the time you may have, does the patient smoke? The patient does not smoke as an answer. And most of the NLP tools would just extract the mention of smoking, and the assumption becomes that yes, the person smokes, when in fact the natural language said the person did not smoke. So what Spark NLP allowed us to do was to only extract positive assertions or positive presence of each of these risk factor conditions. And that really helped us identify which patients were at higher risk or at higher risk factors associated that can be incorporated into the model. Okay, so this is our approach. This is an overview of how we handled or how we took an overview of the data as the patient was coming into the hospital and created a temporal timeline that we can feed the patient's data into a model. So let's say the patient has certain diagnoses associated on day one. They were taking some set of medications that you see in green. They had set of procedures done, and they have some sort of lab measurements associated as they come in. So we would integrate the data by day and collect all of the data associated with diagnosis, drugs, lab measurements, and procedures into the features observed at day one, the 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 demographics associated with the patient, and the chronic risk factors extracted from Spark NLP. We treated them as static conditions or static features, so they became persistent across the history of the patient as it stayed over in the hospital. And then here you see like the aggregation of the patient's data on day one, and similarly we could aggregate the patient's data on day two, and so on. So what we had was actually a temporal view of the patient after aggregating all modalities of data. So the risk factors and demographics became the static context or static view of the patient. And as the patient stayed and different measurements and drugs and procedures was given to the patient, it became a temporal view of the patient over time as they stayed in the hospital. So once we create the temporal view of the patient, that includes the static risk factors and the patient's information per day, our goal was to build a model that can integrate all these different kind of sources of data, as well as find a way to do the use the SRD cohort and the relationships between the concepts that occurred in SRD cohort to our advantage for improving COVID-19 outcomes. So what you see on the left is our way of encoding different kinds of modalities of data. So on top left, what you see is the categorical information associated with patient static risk factors. So age, sex, race, ethnicity, or anything demographical information. And then all of the risk factors that we extracted from clinical notes, such as diabetes, hypertension, smoking, or anything else. And we encoded them as one hot vectors. Now we had the temporal attributes that included diagnosis codes, drug codes, procedure codes, and the lab measurements that were being taken as the patient stayed in the hospital over time. So what we did was we had one hot encoders for that, all set of structured EHR codes, and then we identified the key lab measurements that were important to predicting COVID-19 outcomes, such as creatinine level, and we incorporated the numerical values of all those lab measurements as part of our vector. So what you see here on the bottom left is our vector that encoded all of the structured EHR along with the lab measurement values into a single vector. Now, on the right is our final model, and we call it TransMED, as the model that can enable transfer learning and incorporate all kinds of medical data. So, as I said, the smoking, alcohol, chronic conditions, and demographics go through the static context encoder, and they become kind of an observation at the time of admission, so at time t naught. And what you see here is the temporal encoder that I just talked about here on the left, and that encodes all of our drug codes, diagnosis codes, and lab measurements per day. Now, the information that is collected per day is passed through the BERT layers. And what we did was actually when we realized that the SRD cohort used similar set of lab measurements and drugs and diagnosis codes, we determined that we can train this or pre-train the BERT layers with SRD and COVID cohort. So we did similar processing with the SRD cohort. We encode or aggregate the information of SRD cohort patients per day, and we pass the COVID and the SRD patient cohort information per day through the BERT layers. And that gives us a contextualized patient vector where we can learn the relationships between the different, the lab measurements, the drugs that were being given to improve that value of lab measurement, and how it changes the patient state going forward in a day. So that allows us to learn or improve the relationship learning between the different codes or medical concepts that occur in a patient's stay during a respiratory disease. And once we have these contextualized vectors for per day, then we take the static vector with the risk factors as the observation at time period 0, have the contextualized risk factors over patient stay, and then we pass it through a temporal layer where it could be BERT or a GRE or a feed-forward network that combines all of these patients' vector into a single unified temporal layer, and then pass it through dense to predict a particular outcome, such as ventilation or if the patient is going to stay a particular number of days. So let's move on to results. Okay, so really excited to show you our results with our multimodal model with transfer learning. And what you see on the top left is our results with respect to other baselines. And as I said, we try to predict two tasks that we thought were of real importance to the hospitals. One was, is the patient going to stay in the hospital next 3 or 7 days? And similarly, for a patient coming in, can we predict, is the patient going to need a ventilator in next 3 to 7 days? And we compared our method with logistic regression, BERT, which is another state-of-the-art model for EHR data, and gated recurrent units model. And we observed that the TransMED model, which is the model that we are proposing with transfer learning, that did as well as a GRU model on predicting length of stay, right? But if we started looking at the more rare outcome like ventilation risk, our model did significantly better than any other model out there. So what you see here is that on the patient stay prediction results, we got an AUROC of 0.84 and 0.80. While on this task of predicting ventilation risk, we were able to improve the accuracy from 0.64 with logistic regression to 0.83 AUROC. And similarly, for prediction in next 7 days, we were able to improve the performance from 0.72 to 0.77. So this is a significant jump from any of the other state-of-the-art models out there. And what you see on the bottom of this is the impact of doing transfer learning. So impact of incorporating the severe respiratory disease cohort or the SRD cohort. So top line shows the model results without using SRD cohort. So if we just pre-train on COVID and fine-tune on COVID, the AUROC just remained at 0.71 for the predicting the patient stay, and 0.72 for long-term patient stay. But if we did the transfer learning and use the model pre-training on SRD plus COVID, the accuracy score jumps from 0.71 to 0.83, and for ventilation it jumps from 0.72 to 0.84, and so on. So transfer learning and doing the multiple modalities of data really helps us do better prediction of COVID-19 outcomes. Okay, so another very exciting part of this work was that, we built a model that could take a look at patients' data as they're coming into the hospital and do a good job of predicting with certain confidence that if the patient is going to need a ventilator in next 3 to 7 days, or is the patient going to stay in the hospital in next 3 to 7 days. And it helped hospitals do better resource planning. But as one thing that, as you were talking to the doctors, was that just having a good accuracy is not enough. We want, when the patient comes in, the doctor needs to be able to tell the patient why are they at higher risk of being into ICU or getting a ventilator or a severe outcome. So one of the other things that we also did was really look at how different risk factors in the population were impacting the risk of getting an ICU or a ventilation outcome. And then we also validated that our model is able to capture these risks correctly. So what you see here in this slide is on the left, it shows the model calibration or the model predicted risk for different patients with or without the risk factor present. So CAD is the coronary artery disease, and it's showing how the model predicted risk for when the CAD was present was higher than compared to patients for which there was no CAD. And similarly for diabetes, you can see that the patients who had no diabetes almost had zero risk of going on to ventilator compared to high risk for patients who did have diabetes and they were at high risk for ventilation. And if you see a similar trend across other risk factors as well. And then we went back and said, okay, the model says that, how much of the risk changes as you are on one or the other risk factors. and we validated it against the data for ventilated patients in the cohort. So what you see on the right is the number of patients or the percentage of patients that were admitted and had ventilation outcome, and how it compared to the fraction of patients in the ventilated cohort that did have that risk factor. So you will see that that in general, the admitted population had around 32% of CAD, while the ventilated population had 41% of CAD. In diabetes, almost 95% of patients who got ventilated had diabetes, while only 61% in the admitted population. So you can see that the trends that the model learned and the corresponding ratio of risk as it increases with respect to presence of a risk factor, that the model was able to capture the risks correctly, and the ground truth data validates that the model learns these risks correctly and how it changes with different risk factors. So another cool thing we did was we said, okay, our model is doing well, learning how the risk changes with respect to one risk factor. But what about for patients who have multiple risk factors? So because most of these patients actually did not have one risk factor, they have multiple comorbidities associated with them. So what we did was we again looked at the frequent patterns that are present in the ventilated population with respect to different patterns of risk factors, and ranked them by prevalence. So what you see on the left is the prevalence of comorbidities in the ventilated population as ground truth. And on the right, we did that, we found the average predicted risk score for size 3 comorbidities in the model as predicted by the model, and said, okay, where does the model say is the highest risk patients? And so what you see on the right are the comorbidities as ranked by the model to be at highest risk. And we saw that out of possibly hundreds of combinations of these comorbidities, the top 10 comorbidities as present in the ground truth, they were present as top 6 comorbidities identified by the model as well. So our model just not did a good job of capturing the linear increase with respect to one risk factor, but it was also able to capture the interrelationships of how these comorbidities together are impacting patients' risk. Okay, so just to conclude our work here, we did several things during the course of this project. Which one was that we showed how we can build models incorporating different kinds of data. So that included getting all kinds of information, extracting information from clinical notes at the time of admission, incorporating lab measurements and structured EHR. And then we also demonstrated how we can combine data from actually existing diseases, and what is a good way to measure the commonality or similarity between existing diseases to a new or infectious disease or a rare disease that's out there, and how we can do self-supervised learning models that can combine these or do transfer learning between different kinds of diseases. And not only with the model, the transfer learning model and incorporation of multiple modalities, we also showed that if we can extract risk factors and comorbidity information from clinical notes, we can do a good job of explaining why a patient is at a risk of a severe outcome, and even how different risk factors interact with each other and increase patient risk for a severe outcome. And our methods are generic, and that can be extended to any kind of new disease that we want to model. So thank you so much for your time. Thanks.